I'm going to talk about the AI applications in healthcare data. And, so when I talk about AI, most of the time I'm just talking about machine learning. So I won't spend much time on this topic, but if so AI is a very broad topic, and I'm only using machine learning to deal with healthcare data so that I can make individualized predictions for diagnosis and outcome. This is actually the data from our province, which is Alberta in Canada, and we actually see a very steady increase of disposition rate for antidepressant and anti-anxiety. I think it's really not stable here. And this is the data for substance use. And every year we're talking about 1,000 people. So our own population in Alberta is about 4 million people. So every year the death due to substance is about 1,000, even more. Sometimes we're close to 2,000. And by the time I actually made these slides half a year ago, we were talking about 1,900 deaths. When you compare it, actually, in a province with 4 million people, and we roughly have between 1,000 to 2,000 deaths every year for COVID, between 2020 and 2021. But we also have a comparable number for substance use, like the deaths due to substance use. So we talk COVID deaths a lot, but we kind of like not talking a lot about the substance use deaths. And to give you even a better picture, because our province is a single-payer health system, so we know how people use our health system. Whether you're seeing a doctor, whether you got any prescription drug, those kind of behaviors. So for the same population who actually, this is people using, I think it's people using opioid. And this is the data from 30 days before their death due to opioid-related overdose death. And for those ones who use prescription opioid, they actually, within 30 days of their death, they actually use the health system. So they either see a doctor, or they get some prescription drug, or they for some other reasons. No, that's okay. I think I'll just talk through about it. We actually have over 86% of people interact with the health system within the 30 days of their death. And for those ones who don't use prescription opioid, we actually have at least 5% of them who actually interact with the health system. So actually those people who don't rely on prescription opioid, but eventually they have some opioid-related deaths. So even for them, within 30 days of their death, they actually interact with our health system. 55% of them interact with our health system. So that's actually a lot. This figure actually greatly motivates me to see how we can help them. Because within 30 days of their death, we actually had a chance to intervene, to prevent their death, actually, right? Because we know at least 55% who actually rely on illicit source of opioid, they interact with the health system. For those ones who rely on prescription opioid, over 86% of them actually interact with our health system. So that's actually my strong motivation. Like we already know them in the system. We have their data in our health system, and they actually also interact with our health system. Can we do something? So the current challenges, I think, is going to blink again. Yeah. I think I can predict it because it's on my system. In general, I think I'm not familiar with the system in Turkey now, but I think in general we have a problem with health services because usually we, based on symptom-based diagnosis, we have a low efficiency, high cost of treatment because we usually do a trial and error style to and what's the lack of accessible long-term support. The whole thing is actually relevant to the complexity of the mental illness, and we also have very limited information on separate levels, right? First, levels, because the doctors usually they know exactly the personal history of every single patient, and also on the population level, we don't know exactly, for people with similar So if it doesn't work, we can actually try something else. That's something we don't have right now in mental health. So eventually, we hope to achieve a personalized medicine. For that, we need two things. One is the data approach. The other thing is the computational tools. So that's actually where I specialize in, which is called computational psychiatry, the emerging field in mental health research. So I won't expand here about what exactly we meant by big data, but I think most people here know that each patient, we have a lot of data going on, right? We have our health records, we have the smart devices, cell phone, how you type your cell phone. We have the remote sensoring, like the smart devices, like the rings or the bands, those kind of things. Monitor your technology. Yeah, actually generate a lot of data. We also have brain scans. We have other stuff. So to deal with that data, we need computational psychiatry. So we usually have super high dimensional heterogeneous data now. This is even in psychiatry. And what we really want is we want personalized diagnosis and treatment optimization. So I hope to achieve treatment prediction first before we can optimize every possibility. So for that, we need computational tools, which is a computational psychiatry that is working on. So I work with computational psychiatry using different data, for example, genetic data, brain imaging data. I especially want to talk about the health data. And our problem is that we have a single-payer health system. So basically, our government is also the insurance company. So, for each doctor see a patient, they will bill the government for that activity. So we actually know, how each patient use our health system. So for that one, we have administrative health data. So for short, I call it admin data. So what we use machine learning in this data, on the micro level, individual level, we hope to achieve individualized prediction. On the macro level, we also hope to identify risk and protective factors. So for the individualized prediction, those are very helpful for the clinicians to identify patients and to optimize their treatment. Policy makers, for those ones who work in the government, they actually would like to know what are the risk and protective factors, especially those they can change, right? So some things like they can modify, then they can improve the system. So eventually, I hope with overall approach, we can achieve precision medicine, precision public health. Again, I won't expand on this, but it's actually an emerging field in public health as well, so that we can call precision public health. So try to apply machine learning into this field. We have precision psychiatry, we have evidence-based decision making on the clinical level as well on the policy level. And eventually, we hope to achieve data-driven clinical practice, health system management, policy change, program development, and even legislation. So it sounds like weird to say data-driven legislation, but I think eventually we will, reach there. Again, we're still in a very early phase right now, so we're not there yet. But I think, when you have data there, it's actually, to me, very intuitive to make better decisions based on those data, right? But it doesn't mean that the data-driven decision-making will be absolutely better than just the traditional way of making decisions. But currently, I think it's definitely better than someone just let their head and say, okay, let's do this. It's definitely better when you know more about your population and, I make an evidence-based decision. I will give you some examples here. So this type of study is emerging in this field, and I'm starting to see more and more in this field right now. So when Hannah talked about psychedelic studies, like 20 years ago, it's just so rare that they don't even want to talk about it. Now it's actually similar, so we want to talk about this kind of data-driven research. So we trained this almost 700,000 people, and then we also separate a small portion of that 2014 to 2018 data and try to validate our model findings. So this is already valuable, right? When we do the validation, this part of data, which is actually about 174,000 people, the model never seen this data before. So this is already like a new data. But this actually within the same cohort, which is between 2014 and 2018. So now the really interesting part for me is that now we apply this data to the 2019 data. So this is actually the model. This is actually the data from the future, because the model was trained on the data between 2014 to 2008. So now we're attacking this model on 2019. So this we're talking about 300,000 people. And when we do the testing, so this is just some demographics to give you an idea of how many OUD cases we are dealing with, and the proportion of the males and females, and the age range. So you can see actually most of them are similar. It's just on the testing data set there's some difference. So I will come back to this again. So this is actually the top predictors. I just want to show you the performance of the model on the testing data set, which is 2019. And we actually achieve an error at the curve. So this is actually a common metric for machine learning or for any diagnostic model, to make decisions, for example, binary decisions, to answer whether you have a case or you don't have a case. So the error under the curve is actually over 0.9. So for a model to behave perfectly, you will have a set 1. So this is actually very close to 1. And you can see the sensitivity and the specificity here in okay, I don't have it. So on the right, that's what we call the confusion metric. So you will see the sensitivity and specificity of the model, and we actually have a sensitivity of 93%. But we still have a lot of false positives here that we are trying to improve. But the balanced accuracy here, we're talking about 86%. So that's actually quite high. You remember, this 86% is actually on the individual level. So basically for each new individual, we're saying, okay, you have OUD or you don't have OUD. And for that one, we have 86% of accuracy to test on the new year's data set, which is 2019. So this is actually our model performance, and we're still trying to improve this model without trying to use the same approach for overload. It's actually a more challenging problem. But this was actually quite surprising to me, because remember, this is admin data. So this is not, this is not pharmacogenomics. So this is actually just, whether when you see a doctor, for what reason, what did you get after the year, that's still in a couple seconds I'm going to talk, in our preliminary study, we actually approach almost 90% of accuracy for future opioid overdose prediction as well, even just to use the data. So, there is sufficient information for us to make individual prediction, even in the admin data. So, that's actually a very good surprise for me in this study. So, to just give you some idea about some top predictors. So, whenever I present this to clinicians, they always say, okay, those top predictors, they're not surprising. We know that in our practice. So, and yes, I would say so. But if you use any of the single top predictors here, you cannot predict the individual cases for OUD. So it's actually when you combine them and when you do some combination of them, you can make the individual predictions. So we already have previous opioid-related poisoning, polysubstance use here. You can see actually the top predictors, they are almost all relevant to substance use, right? So that's actually another thing that tell me, we already know who are the high-risk guys. Can we do a better job, to pick them up? Who may need the best and the most emergent intervention? So it's not only about on a populational level. Okay, yes, you have previous opioid overdose, you have polysubstance use disorder. Yes, your risk is high, but how high? How can we help? So that's the question here. It's not only about, okay, yes, we know polysubstance use is one of the predictors, but then how can you help each individual patient? So that's actually the problem here. Yeah, so these are all the collaborators and the founders for my research. And this is we have a computational psychiatry group that is expanding in our university. And this is my contact information if anyone has questions. Thank you.